lung cancer is actually the second most common cancer in men and women. Women, the breast cancer is the most common, lung cancer is second. In men, prostate is the most common, followed by lung. But it actually is the number one cause of cancer-related death. So even though it's second most common, the mortality associated with lung cancer is much, much higher. So it accounts for about 25% of all cancer diagnoses and mainly occurs in older people. And as most of you know, for smokers, the risk is a lot higher than with non-smokers, smokers and people that have occupational exposures. So why is it so important? And as I mentioned, it's a very, very common cancer. You can see the number of cases diagnosed are more than 200,000 annually here in the US and more than 1 million worldwide. But if you look at those deaths, about 150,000 patients die annually of lung cancer in the United States. So the problem with lung cancer is that it does not cause symptoms until it is very advanced stage. So early stage lung cancer, little nodule in the lung doesn't cause any symptoms, which is why it's one of those diseases that it's very important to have an effective screening test. So most patients are diagnosed when they're late stage. There are good treatments available, many advances that have been made in the past 10 years or so, but still late stage, stage 4 lung cancer is still considered incurable. So I just wanted to point out a little fact. This is from the Bonnie J. Aderio Lung Cancer Foundation, which is a patient advocacy foundation that raises money for lung cancer research. And it's not known widely, but lung cancer actually kills more people per year than breast cancer, prostate, and colon cancer combined. And so that is a staggering, number of people. So just a brief overview. If you look at this picture here, the stage 1 lung cancer presents just as a nodule in the lung. Usually no lymph nodes are involved. And stage 2 lung cancer, similarly, maybe a larger nodule in the lung. There might be lymph nodes involved, but there are no lymph nodes typically in the middle of the chest. So usually stage 1 and stage 2 lung cancer can be surgically removed. And those are considered the curable stages of lung cancer, when it's caught early and it can be surgically removed. Stage 3 lung cancer is when the nodules in the lungs are larger, or they're invading the bigger airways of the lung, or they're more central. You can see those lymph nodes marked in red, more central lymph nodes to where they can't be surgically removed. So usually stage 3 is treated with chemotherapy and radiation, sometimes can be surgically removed after chemotherapy. Stage 4 lung cancer is, as you can see, when it's spread to other organs like the liver or to the brain or to the bone. And in those cases, those patients are the ones that usually see me for treatment for chemotherapy or immunotherapy or other treatments, and typically not considered curable. But again, there's many treatment advances and immunotherapy, targeted therapy, that patients are living a lot longer than they used to. So just a little bit of an overview about the subtypes. Non-small cell lung cancer is one of the big categories, 80% of patients. Small cell is a smaller category, 15%, but very, very aggressive cancer. Small cell, and there's other rare subtypes. Symptoms usually is a persistent cough that doesn't go away, or weight loss that's not explained otherwise, difficulty breathing, or any persistent pain. And usually it's diagnosed with a CT scan or a PET scan where we can see the lung nodules or other masses, and a biopsy is done to confirm the diagnosis. And treatment, like I mentioned, might involve surgery if it's early stage, chemotherapy, radiation, immunotherapy. And this is not as much, I'm not going to focus a lot on the treatment, but it's very important to molecularly profile the tumor. That means some special testing on the tumor that might help determine what it's more likely to respond to. So causes. Smoking is still the number one cause of lung cancer. So most lung cancer deaths, about 80% lung cancer deaths, are related to smoking. Secondhand smoke is another big cause. And then there's other occupational exposures, environmental exposures, and sometimes we see lung cancer in patients who have never smoked, and we don't really know what the cause of of that is. And that's actually a rapidly increasing proportion of patients. So other risk factors are radon. Radon is sometimes present in some homes, actually, in the soil, older homes. And that's a significant risk factor as well. So there are actually radon kits that are available that you can buy and use to detect the level of radon in your home. And if it's above a certain level, it will indicate that that home needs treatment to eradicate the radon. And there's ways to do that. There are people that are contracted to do it that basically they do expel it from the soil. It's a big process, but it is, comes into the home through the soil and the atmosphere. Other hazards related to, occupational hazard, smoke and, chemicals like cadmium, beryllium, silica, all of these are potential hazards and, increase the risk. Patients who have had cancer at a young age, and were treated with radiation to the chest, that's a potential risk for lung cancer in the future. So I wanted to just put in a slide about vaping because that is such a big public health problem now. And what it is basically a liquid that contains nicotine and some other chemicals and flavorings. And it's battery operated and it uses a heat to heat up and cause a vapor, and the vapor is inhaled. And e-cigarettes are marketed as a potential safer alternative to smoking, but that is actually not the case. They do contain nicotine. A lot of them contain THC. A lot of them contain flavorings and some compounds that actually are carcinogens, and they're not marketed that way. They're marketed as potentially a tool to quit smoking. And because of the way that it's being marketed particularly to young people, a lot of middle schoolers and high schoolers and young people are using e-cigarettes, and the CDC says that there's over 1,000 cases now of lung injury and associated with vaping. And there are actually 18 deaths that have been reported, not from cancer related to e-cigarettes. Although they can cause cancer, e-cigarettes have only been around for 10 years or so, so it's not enough time yet, although we know that it has nicotine and can cause cancer. But the deaths are related to lung injury related to vaping. And it's actually just a few days ago, the CDC labeled the type of lung injury caused by vaping as E-Valley, and it's called e-cigarette associated lung injury, so e-cigarette and vaping related lung injury. And basically what it does is it causes an inflammation in the lungs due to the chemicals, and glycerin is one of them, diacetyl formaldehyde, those are some of them. They causes inflammation in the lung that leads to a serious lung injury and death. So it's very, very serious. So if you know anyone that uses e-cigarettes or vapes, they need to be informed of the risks associated with it, and it's not recommended by the FDA or any other organization for trying to quit smoking. So a little bit more about the focus of the talk, which is screening. So the National Lung, NLST stands for National Lung Screening Trial. So it tried to figure out, is there a way that lung cancer can be detected at an early stage, since it doesn't cause symptoms when it's early stage. So the population that was selected in this trial were people that were either current smokers or smoked in the past and quit. Because you still have a risk if you quit in the past, you still do have an increased risk of lung cancer. So the participants were 55 to 74 years of age. They had to have had at least 30-pack year history of smoking. That means, a pack year is if you smoke 1 pack per day for 30 years, that's 30-pack years, or 2 packs a day for 15 is also 30. So that was a minimum requirement, and they had to have quit within the past 15 years. And there were over 50,000 patients, and they were randomly assigned, computer assigned, to either be screened once a year with a chest CT scan or with a chest x-ray. And what the study found was that and they were followed for about 7 years, but the screening scan was done for 3 years. They found that the participants who had the CT scan had about a 15 to 20% lower risk of dying from lung cancer than the participants who were screened with the X-rays. And so that led to this was a big study that led to low-dose CT scan, and I'll talk about what that is in a minute, being approved as a screening test for this particular population of patients who are determined as high risk, so current or former smokers. Basically what they found is that if you look on the left side column was the CT, and then the right side was the chest X-ray. So they found on the CT column about 18 in 1,000 people were detected with lung cancer. 18 in 1,000 people died of lung cancer compared with 21 in 1,000 people for chest X-ray. So basically that translates to, for every 1,000 people that were screened, they had early detection in 3 people with the CTs. So you saved 3 people from dying from lung cancer for every 1,000 that were screened. And then in the course of this, they also found potentially other cancers or other illnesses. And so they also found that it reduced mortality from other causes. So every 1,000 patients that were screened, they saved 5 people that would have died from other causes. And so what's the downside of this screening? Why don't we just screen everyone then? If we're detecting the lung cancers early, and if we're preventing them from dying of lung cancer. Well, there were false alarms. So a lot of times we do CT scans on people and we find things other than lung cancer. We find nodules, we find, especially in Arizona, valley fever, that ends up not being anything and never needs to be treated. So about 223 in 1,000 people had at least more people had a false alarm when they did the CT scan compared with the chest X-ray. And then of those 223, about 18 people had a false alarm that led to an invasive procedure, meaning if the nodule was worrisome enough, then they had to have a biopsy and it ended up not being cancer, or they had to have a bronchoscopy or another procedure. And then about 1 or 2 of them had a complication from an invasive procedure. So they not only had a false alarm, but they had an invasive procedure and they had a complication, but no cancer was ever found. Now, of course, the results of this study were significant enough still, even with the false alarm, that it was felt that this should be considered a standard procedure screening for lung cancer. So based on that, it is now the U.S. Preventive Task Force approves screening individuals actually from age 55 to 80, even though the study looked at age 55 to 74-year-old patients. And these people have to be in good health. So if someone's actually having symptoms, then they shouldn't get a screening scan. They should get an actual diagnostic scan, which has a higher dose of radiation and a higher level of accuracy. So people that are in good health that don't have any symptoms but are current smokers or have quit smoking within the past 15 years and have to have at least a 30-pack year smoking history. And then they have to be informed of the risks and benefits of screening, and they have to go to a facility that has experience in the screening and potentially what to do with the findings. So it's important to remember that screening is not an alternative to quitting smoking. So you still, it's not just because you're having a screening CT scan does not mean that you can continue smoking because it'll detect lung cancer anyway. So that's important to remember. But it is now approved for people to receive a low-dose CT scan if they fit the criteria. And then what are the risks? We talked a little bit about the false positives, people getting testing done or biopsies done even if they don't have, end up not being diagnosed with cancer or they have some benign cause. Overdiagnosis, you find other things that may not be lung cancer, but may potentially really never affect the ultimate survival of the patient, and so that's a potential risk. And then the low radiation exposure. So if you look at this graph here, it shows what the radiation exposure is for specific scans. And if you look at the one in the middle that says 1.4, MSV stands for millisievert. It's the sort of the measure of the amount of radiation. And you can see in the course of a routine, air travel, 0.04 millisieverts is the radiation you're exposed to. That's a 10-hour air travel. A chest X-ray is 0.1. So a mammogram is 0.4. So low-dose CT is slightly higher than that at 1.4. But if you look at the average radiation that we get over a period of a year, background radiation just from living life, it's 3 to 5 millisieverts. And a diagnostic CT, which I mentioned is the one that we do for patients that are actually having symptoms that we have a high suspicion for lung cancer, that's 7 millisieverts. So there is some radiation exposure with the low-dose CT scan, but it is way less than the diagnostic CT, and it is comparable to what we see in sort of day-to-day life. What about insurance? Will it cover the low-dose CT scans? Yes, it will. Most private insurance plans do cover it for patients that fit that criteria with no out-of-pocket costs. Medicare will pay if you meet the following criteria up to age 77. So you have to have an order from your doctor that you fit the criteria, and you have to have what is called a shared decision-making visit, which means discussion of the risks and benefits and whether it's a good thing to go ahead with, and also it has to be a facility that does low-dose screening CT scans. So I will end there. I think that there's, definitely this is, there are harms associated with screening, but far less than the benefits is my feeling. And right now the population that is approved to have it is only the patients that are smokers or are previous smokers that are deemed to have that risk. But I think it would be interesting to look at other populations like yourself to see if that's something that would be associated with certainly a higher risk, and see what we find. Okay, thank you.